Welcome to the first day of Let's Talk Clots. I hope you were all out 2 days ago with your birthday hats and party poppers to celebrate October the 13th, which is the birthday of Rudolf Virchow, he of Virchow's triad. My name's Simon Noble. I'm a Marie Curie professor in supportive and palliative medicine, and I have a clinical and a research interest in cancer-associated thrombosis. And as part of the research, for some time now, we've recognized the real importance of involving patients, their significant others, their carers, and members of the public in our research. And it's something that we've pushed for and advocated for within many research environments, both locally, nationally, and internationally. And it gets viewed, very differently by different groups. Some really do feel it's just tokenism and don't quite get it. So what I want to do is give you a very basic overview of patient and public involvement, or I'm going to be calling it PPI, for the purposes of this talk, and share with you some examples that we've had in our research into cancer-associated thrombosis. Now, let me tell you that I am in no way class myself as an expert, but there is that saying, which is, in the world of the blind, the one-eyed man is king. And most of the audiences that I've spoken to previously have known less than me, so therefore I have come across being knowledgeable. But if I were to be in the same room as a PPI expert, I would look a complete amateur. And so that is the kind of caveat for this. I'm hoping that we'll have some time for questions or comments at the end. But I'm going to hope that Joe may be able to manage those for me, but we'll find out. Do apologize for my bright shirt. It is not just because I am being eccentric. It is that the university has put the heating on in the building and I am sweating buckets now. Before I start, I just want to make a plug for my colleagues and friends in the north. They're having their second cancer-associated thrombosis summit of the North of England Oncology group, CAT NEONC, led by Professor Anthony Maraveas and supported by other colleagues and friends, including Annie Young. And so I would encourage you. It is a I believe it's a free event. If you kind of get details from the website there, but I would encourage you. The program is excellent and it covers all aspects of cancer-associated thrombosis. So let's talk about public involvement in research. And it brings me to a quote which I loved when learning of it. Louis Armstrong, Satchmo, the great jazz singer and trumpeter, was once asked by a journalist, "What is jazz?" And his response was, "Man, if you got to ask, you'll never know." And this kind of resonates with me when it comes to PPI, because people often think they know what it means. And then when you dig deeper, actually, they haven't got a clue. But they thought they did. So they were what we would call unknowingly unknowing. So they thought they're doing a good turn here, thought they're supporting public involvement, when in fact, they weren't really. So there are certain things I'd say that it is not. So recruiting patients to a study is not public involvement. That's recruiting. You're not actually involving members of the public or patients in the actual conduct of the study. So any study which is about patients is not PPI unless the patients have been involved in the design of the study and the running of it and have actually contributed to it that way. Having subjects in a research project, which, you're talking about most biomedical studies. Can I just check? I've had someone say there, am I the only one who can't hear Simon? Can I have a few people? No, Joe can hear me. Can everyone else hear me? Can a few people just say if you can hear me or not? Christopher, yep, other people can hear you. Okay, so Sarah, I think you need to sort it out your end. I do apologize. Um, PPI is not developing a quality of life tool. You may involve patients. Um, you may be assessing patients' opinions on that, but it isn't PPI as such. And also, this is the other one that's become sort of quite fashionable or considered necessary, is whenever we do a study now and we're rushing to get the forms done and we're rushing to get um, the application signed off. Oh, we need to show some patient involvement. Quick, let's write to that charity and see if they will send us a letter of support, and they go, oh yeah, sounds good, yeah, oh yeah, we think this is a good project, hey, we've done our public involvement. No, that's just getting a letter of support, which, unless you've actually engaged in that patient organization to the design of the study and whether the actual study is a good idea, all you've done is just get a tacit support from them. And actually, grant groups are really wising up to that, so I'll talk about some of the things to be careful of sooner. So what is it? Well, if you use various definitions which have come from the um, certainly the UK Health Research Authority. So PPI is research carried out with members of the public or by members of the public rather than to, about, or for them. So it's actually involving them as true and meaningful partners in the process, such that the public involvement contributors will have as much say as other members of the trial steering committee, and will be bringing a perspective that the other members of the steering committee won't always bring. Now, it means that patients or other people with the relevant experience contribute to how the research is designed, conducted, and don't forget, disseminated. I think whenever we put in a grant application, we forget about how we're going to disseminate it, how we're going to have a route to impact, and we often underfund or undercost our studies from that perspective. And when they come up with the definition, they specifically say it does not refer to research participants taking part in a study. So why should you engage in it? Does this sound like a bunch of tree hugging hippie crap, or is it actually, is it a benefit? Well, if you're in the first group who thinks it's tree hugging hippie stuff, um, well, there are drivers for it that you need to be recognizing. And even if you don't buy into it, you're going to have to demonstrate that you are involving public involvement partners. The benefits and the drivers are that actually there's more financial scrutiny on grants now. The days of just being able to go and get a grant off a wealthy benefactor because it sounds like a good idea to them and you've managed to schmooze them. We're now expecting things to have, peer review, to go through a panel, to be properly evaluated. Um, and because money is scarce, the funding bodies, the charities that fund, the government authorities that fund, they have got to very much scrutinize where they spend their money. So it is far more important for them to know that they are getting value for money, that what they are supporting financially is not just an interesting scientific question, but it is of relevance, and that the research is relevant in the long term for patients. And I think, I know that there's some established researchers on this on this call, but to be able to identify what the likely impact and outcomes of your research are going to be is important, and to actually involve your public involvement contributors in that, who can say, yes, this is of importance and this is how we can see it affects this patient group, is absolutely vital. I certainly think the other thing is that if you have public involvement contributors who are able to comment on the protocol, help work up the protocol, they are often very helpful in identifying the likelihood that you will be able to recruit from this patient population. I'll give you examples later of times where actually our public involvement contributors have actually prevented our study from tanking because their perspective actually changed the way that we looked at the project. And as I've said before, it also helps identify a road to impact, a way to disseminate, the appropriate people to disseminate with. And often I think when you are engaged, for example, with professional patient groups or charities, they are often already linked in with some of the policymakers, some of the some of the big organizations that will disseminate information. And so using them as partners for that is also very helpful. So I'd like to suggest that meaningful PPI increases the likelihood of funding. Maybe that is overstating it. What I can say is crap PPI or absence of PPI will increase the likelihood of not getting funded. And here just two, the NIHR and the UKRI, MRC, Medical Research Council, actually will have public involvement contributors. They will have lay people. They may have patient group representatives on the panel who will be looking at the public involvement strategy. And these people have often been at this level, these people have often been involved in public involvement for some time, and they will sniff sniff a bad PPI or a tokenistic one a mile off. And they have a very significant voice around the table. I have sat on some funding panels where I have seen, rubbish PPI there, or even just clearly they had no idea what PPI was. And that was probably the thing that tanked the application of a study which was on the, on the cusp of should we support or should we not. The other thing that is really important is if you are applying for a grant, you make sure that the research staff are costed into it, and every member of staff will have a certain amount of their time. The idea that member of public or a patient is therefore going to turn up and give their time for free is actually very much devaluing the expertise that they bring. And it is essential when you put in the grant that you actually cost your PPI adequately. So there are recommended established tariffs for patient time. So for every hour that they contribute to the project, not just coming to meetings, but looking over projects, looking over the protocol, looking over the patient information leaflets, taking them to other groups and discussing them. So that should be costed in, travel should be costed in. And also, if you have someone who has a unique perspective on something, so for example, if we were to do a research project in the kind of, something to do with the experiences of or pressures on, caring for a sick loved one, if that person is having to leave the loved one to go and do their PPI work, you want to be costing in your project to actually cover the carers' costs as well. And, we do have a couple of public involvement experts who do request that we do that. So don't undercost this. And sometimes I've seen feedback on grant applications which have said it's very good, but they've really undercosted the PPI work. And what I would say is that the days of just getting a letter of support from the local kind of content relevant charity, I think those have gone. I think now when they look at the letters, rather than just we support this project and think it's an important one, they're looking for whether, in what way the grant applicants have engaged with the patient organization before the study. They are looking at what involvement they're going to have and what the organization can bring to it. So it may be we are here to provide, give access to patient organizations, to patients with the relevant experience. We will actually be able to recruit someone to be a member of the trial steering committee. We can, be used as a vessel for dissemination. We can actually host, a patient, a kind of a group meeting, a town hall meeting of patients, to actually feed back the data. So actually the engagement with charity or a patient organization should be thought through. And the best way is to talk to those groups and say, well, what can you offer? What can we do with you? So I have a PhD student at the moment who is just thinking about what her PhD project will be. We're going to actually meet one of our public involvement contributors before she's even started writing her protocol to say, well, what is important to you from a patient perspective? Also, many of the publications now are actually wanting to know how much public involvement you've had. So here's the example from the BMJ. There is greater emphasis on justifying why the project was undertaken. So public involvement statement of, that this was highlighted at a patient involvement group, that this was an important area. How it's relevant to patient care. You often have lay members on editorial boards now. Some will have 50-50. How much support the contributors received, or were they just pulled in and told to sit there on a committee and say nothing? And actually, um, some journals actually will have a standard pro forma in which you state under each of these headings how much PPI involvement was present in the concept, the design, throughout the process, etc., of writing a paper. My computer's wanting to restart. I hope it doesn't restart now. So benefits of PPI. Actually, the Health Research Authority strongly believes, and I agree, that academic teams engaged in PPI conduct better research because the studies they are developing are of greater relevance to the participants. The feedback they get helps them design studies which are more acceptable to participants. Nothing worse than doing a project which sounds really clever, but then no one wants to be involved in it because they find that the intervention's too unwieldy, or they just find it's going to be too burdensome to do. So to actually have patient involvement early on, or public involvement early on, is very helpful. And I've been sat there in front of an ethics committee when they said, well, we think that this is a problem. And the public involvement person said, well, I've already discussed this as a focus group. And the opinion is, no, that is not a problem because of, and that's very powerful feedback because it actually, a lay person or a patient is more likely to have that perspective than someone on the committee. We know that when we have the patient information leaflets and the consent forms, having patients involved in reading it will be able to tell you, look, I don't understand this. This is gobbledygook. It needs to be changed. It needs to be simpler, or this bit needs clarifying. Patients will have a better experience because we're not putting them through unnecessary tests, interventions, or evaluations. And also by thinking about public involvement throughout this process, when it comes to the end and actually disseminating the facts, you'll have already thought about that. You'll already have put into your protocol and your consent form, would you like to know the information? Would you like to be kept up to date? Would you be interested in coming to a meeting later to discuss the findings? Another way public involvement has been very useful. I don't know how many of you are familiar with the James Lind Alliance or even James Lind. James Lind was a Scottish physician who conducted the first randomized control trial in which on the ships going to Australia and ships going to America, I think it is, he'd identified that, a lot of these people died over the year on the ships of scurvy. And his hypothesis was that vitamin C or something contained in citrus fruits was helpful. So he randomized one group to have a lime or half a lime a day and the other group not to. And he found that those who were given the lime survived. They did not develop scurvy, whilst those who didn't did develop scurvy. So that was the first RCT. Hence, Americans call the Brits limeys. So the James Lind Alliance is actually a non-profit making group that involves patients, carers, and clinicians to actually set priorities for research. And they have a very robust pre-agreed process by which they often will have an online communication where people will highlight what they think is the most important research to be done for a particular field, and then there is a robust process by which they are prioritized. And whilst all of the things raised will be in the report, the top 10 research questions for that group will then be published. And, I know for a fact that some of the grant awarding bodies will look to the statements from the James Lind Alliance as to what to support or what themed calls to put out. Our research group conducted a priority setting process for palliative care. And that actually highlighted several areas where the patients, public, and researchers felt were very important. Not all the things that you would actually think would be most important to you as a researcher or as a healthcare professional, but to patients and their carers were really essential and unanswered questions. So, that is once again a way the patient and the public voice can be involved. We are getting more and more people looking at the importance of setting priorities for research. If we focus now more on thrombosis, there was a joint paper published by the American Heart Association and the ISTH on research priorities for VTE. And what they identified was these 4 different theme areas or areas that should be looked at. And their process was very clear in the paper. It was a crowdsourced project with Twitters and mail shots to people who were known to be clinically or research active. At the American Hematology Association Vascular Discovery Scientific Session in 2018, they had an open discussion about this, and 319 respondents in total from various organizations across the US, Europe, and Asia, about 16 organizations and societies in total, provided feedback. And then the writing group met and drafted a paper, and it was published simultaneously in Circulation and Research and Practice in Thrombosis and Hemostasis. And if we look there, we can see that there were a large number of organizations and societies represented. And if we have a look at the number of patient organizations involved, there were none. So not one to be quiet and stick one's head above the parapet. Myself and some colleagues who have been championing PPI, including our PPI lead, Kathy Seddon, who is one of the most amazing colleagues I've ever worked with. We actually wrote a letter to the editor, patient public involvement and engagement in thrombosis research, not just for the intrepid. Now, having received kind of letters to papers that I've written, I know how much you hate every tooth in the head of the people who've written them. But actually, we did try to write a supportive but critical friend suggestion that if we're going to be looking at priority setting, we are missing a vital key here. Now, one thing I would say is the irony being this was published in RPTH. Circulation did not publish it because they have a policy which is they will put a limit on authorship of 3. And therefore, if we had all 4 of us, including our public involvement contributor, we weren't able to publish it, and we didn't feel that anyone's name should be taken off since we'd all contributed equally. So there is a certain irony that we couldn't write a PPI letter to Circulation because we couldn't have the PPI's name on it. But we did get a very good measured but supportive response back from RPTH and our colleagues. I know RPTH actually is a journal which embraces patient focused, patient perspective, patient experienced research, and so therefore the concept of public involvement in research is not something that there's any resistance to. So you never done it before. What are the basic principles? Well, involve the right people, involve enough people, involve those people enough, and describe how it helps. Now, the reason involve the right people is so essential, and these are AI generated. Um, One of the problems with public involvement is that sometimes the most willing and articulate people who are putting themselves up to be public involvement experts are not representative of the population that you are looking at. Now, to have someone who can just be empowered enough and is able to speak and give a patient perspective, you can come from any background. But what you do not want is to have pot of a pool of public involvement experts who are all clones of Roger and Ethne here. Roger spends his time rotating between the Rotary Club and golf and does a lot of work on public involvement, and he's very good at it. It means that he spends less time writing angry letters to the Guardian, so he feels his life is more purposeful. Likewise, Ethne here is superb, but she's got a bit disenfranchised with the WI and the neighborhood watch, and so she's wanting to focus things on something else. Once again, these people have a lot to bring to the process, but if I were undertaking, or one of my colleagues is undertaking a project looking at how we can engage teens from um, female teens from um, poor areas to engage in a vaccine, an HPV vaccine program, you really don't want Ethne to be the person who is going to be the person representing. It's going to be far better if you've got Bronwyn here, who actually understands the issues, will understand the best place to engage with um, the potential patients to recruit. Because sometimes, if you're wanting to recruit people doing it from a clinic, it may be better to be doing it from the local miners club. It may be better to do it um, from one of the local kind of community halls. In the same way, if we're talking about industrial related respiratory diseases, um, Jethro here is one of the last tin miners in Crofty, is going to have a better perspective on things and the needs of patients and carers than, say, Roger, who was a commodities manager all his life. So involve the right people, but also involve enough, because Roger and Bronwyn there may give certain perspectives, but they may not give all of them, and they may not actually be able to help to contribute to every part of the process. So I think the idea of having just one public involvement person is not right. You need to have at least two. So we try and have one who's more experienced, ensures the whole process occurs, and we have someone who I think is a content specialist. And you may need more depending on the scope of the project. And um, if you've got a population you're investigating which is very heterogeneous, you may need more. If you're looking at cancer as an entity, and the rep you have is someone who has had um, curative treatment for early stage breast cancer, their perspectives and experiences are going to be different to some gentleman with metastatic prostate cancer, for example. So they need to have enough content understanding. Sometimes you may even find that it is very hard to recruit the appropriate patients because they tend to be too ill. We've done a study recently on malignant bowel obstruction, and to try and engage with those patients has been very difficult because they're just too poorly. And so there we were recruiting carers or next of kin who had experience of it and could give some sort of perspective. So involve them enough and involve them as early on as possible. I think is so important. We try when we're applying for grants to be able to talk about how we've involved patients right from the start, and also to be involved in as many aspects as possible. Now, I'm going to give you an example, which is Hidden 2, which is a hospital inpatient DVT detection study. Now, Hidden 1 was published in the Lancet on Lancet Hematology. And it was a study in hospice patients cancer patients admitted to hospice. And it was a prospective observational study in which we undertook Doppler ultrasound of their upper leg. And what we found, to our surprise, was there was about a 28% prevalence of iliofemoral DVT. It had very little symptom burden, if anything. And also, those patients, there was no survival disadvantage. It didn't shorten life. It was also a population who were very poorly. They had ECOG performance status of 3 and 4, a median length of survival of 44 days, and also 40% of patients screened didn't go into the study because they were admitted for end-of-life care. So it highlighted some very important things with regards to thromboprophylaxis in hospices. And we held a round table meeting with stakeholders from oncology charities, palliative care charities, thrombosis charities, and also different professional bodies with an interest in thrombosis and hemostasis. And further need for research was identified that this is all well and good, but the majority of palliative care patients were admitted to hospital, acute hospital. And are these data transferable? Because there was a perception that actually the patients admitted acutely to hospital are a different population. And that was the basis of us applying to study Hidden 2. And members of that round table actually worked with us in developing the bid. And the feedback we had was that the PPI was very strong in putting the case forward. And also because of the involvement in the public contributors throughout, it was also able to demonstrate a route to dissemination and impact later. Now, there was one time in Hidden where we were really struggling to recruit, and a couple of the researchers had said we really struggle to approach palliative care patients when they're sort of sat in a chair in medical admissions. We just feel it's awful. We kind of then take them off to do a Doppler. They come back and sit in their chair, and we just don't feel we can approach them. It just doesn't feel right. There were two public involvement contributors at the trial steering group, and they both said the same thing, which is, well, you're only going to know if you ask us. It's not for you to decide what we can and can't be approached about. We're adults, we have capacity. If we don't want to participate, we'll just say, but you're taking away from us the opportunity to be involved. What was fascinating with that was that the number of patients that have been recruited in that site in total since the trial had opened, the following month, they actually recruited 3 times that. And the team said that there was a fundamental change in their mindset and that the contribution of the public involvement contributors was the key component. The other thing is to describe how it helps. So in which way were people involved? What did they do? Did they make any difference? Now, as time is moving on, I just want to quickly move on quickly. There is a study going on at the moment called Serenity, and it is about looking at developing a shared decision tool so we can review antithrombotic use at the end of life of cancer patients, because there are data which shows that the rate of bleeding increases to about 10 to 12% in cancer patients at the end of life, and that the majority are still on anticoagulants at death at a time where end-of-life medicines should be able to manage any symptoms associated with VTE. And we have a public involvement strategy throughout this process. And these are the guys. Kathy Seddon, who I've mentioned there, is an absolute gold dust. And what she's doing is providing overall scrutiny of the whole process. But then we're having public involvement contributors at every stage. And wherever possible, we're having the involvement partners actually taking part in more than one work package. So there's some continuity and handover. So if I can just show you this, and this is all these data here are being published in a paper as we speak in Thrombosis Update. So it's not published yet, but it is just under review. And it's just showing various research activities that are being done with public involvement contribution. And that is just another complicated slide showing various aspects of it. And there's a strategic level you can see at the top and all the things, but then things that are being done at each of the work packages of this 5-year project. Now, if there's one slide that you remember or you go back and take a look at, is this, the Public Involvement in Research Impact Toolkit. This has been designed by colleagues in Cardiff University and public involvement experts. And what it's done is it's provided a process by which you can align your public involvement activity against the UK standards. There are standards that are expected to be adhered to. And if you QR code that, and I know that these slides are going to be available online, so you could QR code it, or you could, if you put PIRIT or Public Involvement in Research Impact Toolkit, Cardiff University, you will find a link. You will see that there is a planning tool, so you can see what you could be doing at each stage of the project, and there is also a way of keeping a record as well. And this is what we do custom and practice in all our studies now. So finally, yes, Christina, Roger does have 3 hands and he has vitiligo. Just seeing your messages there. Going back to Louis Armstrong, when he was asked, what is jazz? Man, if you've got to ask, you'll never know. It's actually an apocryphal story, and that is not the true answer. History shows that what he actually said when asked, what is jazz? He said, man, if you've got to ask, then shame on you. Finally, I would just like to thank members of Work Package 3 in Serenity, who have also really championed public involvement. And these are my colleagues in cancer-associated thrombosis as Simpsons characters, Mark Carrier, Jeff Swicker, Aggie Lee, and Alok Khurana have always been incredibly supportive of this work. So thank you very much. And if we've got a few minutes, Joe, we can have some questions. I will just stop sharing my slides now if I can. There we go.
People excuse me, but yes. So while questions come in, I have a few points. Do you know about if there's any training available or guidelines to help people who are setting up research where they can either look to develop training for the patient and public involvement members or signpost them to?
Yeah. So first thing I'd suggest is I would look to see what your own institution has available. I mean, in our university, in our school, we do have public involvement leads, so they are the go-to people. So I would also go on to the NIHR Health Research Authority. They've got a lot of information there about public involvement, and then also you've got the public involvement groups as well. So there are quite a few places that you could go. So I'd say UK Research Institute, UKRI, has its public involvement group, and there are various things there. With our patient and public partners, for some studies, we will even have them GCP trained so they can get a perspective of what we as the researchers are having to undertake and what regulations we're bound by.
I think that's really helpful, especially the last bit, because to understand how the process works is as important as participating in it as well, isn't it?
You've got to know what you're getting involved in. I think the thing that is always very clear in any engagement that I've been involved in with charity work or with research, when you have public involvement, you need to understand why that person has approached you to be involved. Now, there is almost always a story. That person who has content expertise may have been bereaved. They may have an illness which, they've got an experience which can help. Now, those experiences are invaluable, but one also needs to know that that person is coming to contribute to the process and the project at hand. and not work through their own gripes or their own concerns. You know, I've seen people who've come and said, why aren't we doing this? Is, well, that's not the project. Well, I want this done. No, that's not the, well, that's what happened to my mum and I want that done. They're actually bringing their own baggage to it, whilst actually their baggage can contribute and we can also support them with that. But it can sometimes disrupt the process and not actually what you're involving them with. So sometimes, you know, it's, you know, you, when you recruit, you will interview these people. You will see whether they're a good fit, that they're going to work well with the group or not. Or if they have perspectives which you think are absolutely gold dust, you must have them. But there is going to be some challenges. You know, I would then have someone who would specifically mentor them.
Yeah, I agree. Some of the best processes I've seen or heard have response from are those that did have interviews, so that both sides understood what was being asked or expected of them, what they were committing to, and what they could offer, whether that was from time or experience or taking a more holistic view, all sorts of things.
Yeah.
The other thing that we've had feedback on that's been really useful is not just the training, which is vital, but that during the specific elements of the trial development, shaping, and then onto approval and launch, is that the managers of the trials actually have regular update meetings with the
Yeah.
PPI representatives to make sure, just from little things like, do you understand what this is, to any questions that arise, anything, it smooths it out, you feel included, and you've had really positive feedback when that's happened.
I mean, I have had such good support in my studies from our public involvement contributors that, you know, they are always involved. And what's happened now is they know how to contribute, because I'm not having to go, what do what do our patient partners, what do our public partners think about this? And they also feel confident enough now that they know what their role is. They know that there are bits they don't understand. And they may say, look, I don't understand that. Well, what's that? What's that about? Because if they can't understand it, how are we going to get that information across to the people we're trying to involve here?
And I think that's why it also goes wider. So from the study development and design through the process, right through to patient information, and then the getting the messaging out there. Because just as you exampled in your talk, approaching people, having that talk, rather than the presumption of, well, I'm going to do it this way, can really further the project and
Yeah.
getting it to the people you want it to reach as well.
Yeah. What I feel very strongly about is that I mean, Healthcare Research Wales actually has a pool of public involvement people, so you can actually say, I'm doing a study. We would really like to have, you know, involve some public involvement contributors. Who could you suggest? It's to do with this sort of project, and so that you may have someone who kind of knows their stuff, and then you may say, well, actually, we'll also engage with this charity and see if they've got anyone they can suggest. And I know that Thrombosis UK, you know, we've often put people in touch with people we know who live locally to it. You know, I've had several contributors from Thrombosis UK who, you know, they live in Wales, they can contribute to that project, and they've been invaluable. And they are an integral member of the team. They will contribute to the protocol, they'll discuss the analysis with us, they'll contribute to the writing. You know, they are also authors on these.
Totally agree with you. It just raises the study to another much more meaningful level, and it's a true collaboration, which it should be, isn't it?
And I think the thing that I saw with Hidden 2 was, if it hadn't been for the contribution of the patient partners, we would have failed to recruit. We would have been dead on our backsides.
It's a challenge. Yeah. Thank you, Simon. I'm aware of the time, so we do need to draw this to a close, but thank you so much for a really insightful, rarely discussed, so valuable talk on this important topic.
No, my pleasure. Thank you.
See you later. Bye-bye.
Bye.